that new normals obliged. We are distant, we are distant, and but we have to learn. So today is about frequently asked questions round table. So we are here to answer some questions. Those questions were supposed to come from the 2 previous sessions we have in the past, and some questions have been sent to us in box. Many people who missed first or second session emailed us some questions so that we could help them to catch up. As you know, we are running 2 different levels of certificates. The first certificate will be delivered after April, meaning after 4 sessions. And the second level 2 certificate will be delivered at the end of December, meaning this is the 3rd session. Whoever has followed 4 sessions or 3 sessions at least will deserve to have a certificate. And Alana is helping us on that. We may organize a small test in April just to make sure people followed what we've been discussing, so that we deliver the certificate, not a certificate of just attendance, but certificate of completion, because you will have to answer some questions to show that you understood what we taught. So that's why we are taking this session to answer for some questions, to catch up with some, so that you are ready to follow the next session, which will be in April, with some questions from the audience. And then we close the first level. So today we have 7 questions which have been sent to us, and we will go 1 or 2 by 2, answering them until the end. After 40 minutes, we will break out in a small session, breakout session for discussion with the co-panelists. Then after, we'll come back again for another session of few questions and where you think we should clarify, then wrap up. So next session for the 7 questions we receive. Next slide. Those all the 7 sessions have been grouped in a session we call escalation of care. So the first question was, how do we do triage and admission? What are the criteria for triage and admission? Please, for those who are with us in the audience, please start putting them down. So at the end, you will see if those questions have been answered or not. Then you can email us, you can write in the chat concerning or addressing any question which was not answered. The second question is, how do we ensure isolation of suspected COVID-19 case? The third one will be classification, mild, moderate, severe. What are the criteria of classification? Are all COVID-19 cases the same? When do we declare a mild one, a moderate one, and a severe one? And how do we manage? Then we see, how do we escalate, protocol for escalating care in oxygenotherapy for severely compromised COVID-19 patients. Then the 5th one will be to decide when to decide to call a senior physician or to call the ICU team for managing your case, meaning transfer of the case to passing the hand. The other one will be, if no ICU at your hospital, how do you decide when and how do you decide to transfer case to another hospital? The last but not the least will be to recognize how ICU care can be provided outside a well-recognized, well-settled ICU. So those are 7 different questions my team and I will go through and come up with answers and explanation. So at the end, as I told you, feel free to ask whatever you can't understand so that we move on. So I will pass the baton to my colleague, Francois, who is a full-time worker in the COVID center in Rwanda. So he will take us through the admission and classification into mild, moderate, severe. Francois, the floor is yours. Next slide, please.
Okay, thank you, Professor. We have this case of 36-year-old male who had 2 days cough and fever and has been screened for the COVID factors and then being put on facial mask for things. The question like the triage, why do we have to triage such patients? Patients may come in many and then you have to do triage. You sort out people. Can we move? Yeah, as you see this image here, there are things which are really in a mess. But after you do the sorting out and put in order of those things who are in a mess, you may know from where to start, and then you may know the placement in the correct place of your patient after you put them in this order as you see to that image. Then after that, you may think who to admit and who doesn't meet criteria for admission. From this image, let us go then, after we do this sorting out, who to admit, who not to admit. As you see, after you do the triage, we are having like 5 categories or 4 categories of patients in suspected cases or presumptive cases. We have to know that among the presumptive cases, only 30% may be after 3 days confirmed positive. And when they are confirmed positive, then they come to be a confirmed case, which we read then to be in severity classification in moderate, severe, and critical, as we will discuss in details by development later. Then after this, then we will have the recovered case after those confirmed case has been correctly managed according to the protocols, as we are saying. So triage admission have to be met in these 4 categories. And now let us go to the severity. If they are confirmed, who is mild, moderate, who is severe and critical? Here is like the standard showing among the confirmed case, 80% are moderate to mild to moderate, whereas 15% are severe illness and 5% are critical. The outcome of this 5%, it is still not data, confronting data to confirm that. So who is the severe, who is the moderate, who is the critical? Please, can I have that slide? Keep going. So when we come to urinary severity then, we are having at the first phase, the positive patients who do not have any symptoms. We call them the asymptomatic. But after the asymptomatic, in this classification, we can have also the mild illness who are positive and having the mild symptoms as we discussed in the previous sessions. So those patients who are having fever, non-specific symptoms like loss of smelling, and also without dyspnea. So there is no features of pneumonia. When it comes to moderate illness, so they are having positivity. Now, on top of non-specific symptoms, we may have the features of pneumonia, abnormal X-ray, dyspnea, but they still having a good SpO2 above 94. Then we go to the severe patients. So can we go to the severe one? The severe patients, COVID patients, so they are now starting having tachypnea. They are having the respiratory rate, which is high. In our COVID center, we are used to have the respiratory rate even above 60 breaths per minute. So with this severity, the lung filtration test actually have to show more than 50% as damaged lung. And these patients are different from the moderate as we discussed above. They have to be saturation, hypoxic to below 94% on room air, but pay attention on this PF ratio, the partial pressure of oxygen over the FiO2 needed. As we are not having invasive material, we are using saturation, oxygen saturation over the FiO2 we are providing. And if that ratio is less than 300 millimeter micro, so the patient is now in ARDS with the three classification of severity of the ARDS, which we not discuss at this point. So from this, then it comes the critical illness, the 5% I said, whom may go in respiratory failure, sepsis, or multiple organ dysfunction, or in shock and the complications of the COVID. So with this severity of illness, we are having this a patient, and we have to admit them together with other patients, or are we have to isolate them to any specified unit? To this question, maybe Liberata can help me the next.
Thank you so much. Next slide, please. Thank you. We still have our patient of 36 years old, as has been presented by Dr. Xavier. He comes in with 2 days cough, shortness of breath, and fever. Then we need to screen this patient for severe acute respiratory syndrome coronavirus 2, as it is a virus which causes COVID-19. We need to screen this patient so that we will be able to know if he qualifies to be tested and know what we will do after testing this patient. This patient, when we have a patient like this, we need to start screening. Next slide, please. When we are screening our patients, there are some questions those we ask. One of them is the signs and symptoms that this client is experiencing. For this particular patient, he comes in with fever, 2 days cough, shortness of breath. So those are the signs which are specific to COVID-19, but we can ask more questions to make sure that this really patient had risk factors for attracting COVID-19. We have to ask questions like the recent history of traveling. We have to ask the profession, like if he's like a driver who is crossing borders day to day. We have to ask if he's healthcare providers. We all know that healthcare providers might be at risk of attracting this COVID-19. And again, we have to have in mind that some people might be contagious, but never show signs and symptoms. So this is why during screening, we ask those questions. We check body temperature. You see what the nice lady here is doing. She's checking body temperature, and I'm sure that this is done everywhere in our country before entering in taxi parks, in different institutions. You need to be at least checked for body temperature to rule out if you have some signs and symptoms of COVID-19. Next slide. Next slide. So now, if we have asked those questions, whom will we test to rule out if he or she is having COVID-19? Whoever will be coming in with signs and symptoms of COVID-19 should be tested. And if a patient through our questions has told us that I've been in contact with a person who is confirmed COVID-19 positive, we have to think immediately about testing this person. The cross-border truck drivers, they are persons who are at risk because of those movements they are doing. So we need to test them and find out if they are negative or positive. We healthcare providers, our support workers, whenever we show signs and symptoms, we should immediately be tested and rule out what's going on. Next slide, please. If we have decided to test our persons or our patients who comes to us, we need to know which type of test will we order for this patient. There are types of COVID-19 tests. We can test the viral test. We can do viral test, or we can check for antibodies of this, which was built by the body after getting this infection. So among viral tests, we have two. We can use an antigen rapid test, or we use a PCR test. So I know we will discuss much about this in break sessions. We'll be looking at each test and how long will we get results, what is the advantage and the disadvantages of each and every test. Next, please. So now, if we have tested our persons and find that maybe they are positive, we need to isolate them so that we stop the spread of infection to other persons. Isolation strategies. Normally, there is a specific room which is called airborne infection isolation room, which has a negative pressure compared to the surrounding areas, and it should have accessible sinks inside of it, and alcohol hand gel dispensers, of course, to keep hygiene. These are the ones specific to COVID-19 patient, but where they are not, because like in our context, you might not have these specific rooms. What do we use? What other options do we use to isolate our patient? I need to hear a bit from participants what we are using to isolate our patient. Can you chat to me, please? What are we using for isolation? Do we have airborne infection isolation room with negative pressures? We use home-based care. These are the ones who are in their homes. Mm-hmm. So for home-based care, how will you isolate these persons? How long? They don't have negative pressures. Mm-hmm. So they advise, thank you so much for your response. They advise according to WHO, where there is no these specific rooms, we need to have, yes, isolation rooms, which are well ventilated, but closed. And again, they should have those means of hygiene, like sinks or other source of water. We all know for our context, we have what we call kandagirukarabe. I think maybe we'll have an image, but this will help at least those who are entering in or those who are inside those isolated rooms to keep the hygiene and stop the spread of infection to other persons. Next slide, please. So this is the test which will be discussed in the breakout sessions. Thank you. Let me give the floor to Dr. Jackson. We will discuss this slide during breakout sessions about the test. Thank you so much. The floor is for Dr. Jackson.
Hello.
Hello.
Are you hearing me? Are you catching me?
Yes. Yeah.
Good. The same patient that Xavier presented deteriorated with can you share the slides again? Deteriorated with worsening respiratory status of our patients. And then
next slide, please.
Next slide.
Okay.
Yes. The same patient that Dr. Xavier shared with us deteriorated, and the nurse in the ward called you to evaluate. That time the patient was desaturating to 88%, and an SpO2 heart rate of 108, blood pressure of 110 over 56 millimeters of mercury, with a respiratory rate of 32 cycles per minute, temperature 38.7%, which shows that our patient deteriorated on respiratory wise. And as you can see, this desaturation went down. And I want to hear from the charts and the audience, when should oxygen therapy be escalated? Remember, the patient was on face mask, and what can be done to increase the respiratory rate, to increase the saturation, and what is the role of awake proning? Later on, we shall discuss about proning, and we can hear from the participants into the chat. Just like 1 minute. I cannot see people chatting. I can see as someone said we should escalate as the patient was still hypoxic and short of breath. Yeah, thank you so much. These are good answers. I can see someone said we need to go to non-rebreather face mask. Someone said we can put the patient on ventilator machine to increase her oxygen saturation. And then one said there is a need to escalate oxygen for sure. These are really good. And the last one said we need to awake prone position our patient and in recruitment. These are good answers. Thank you so much from the audience. And someone said when oxygen is less than 92%, we need to offer oxygen, which are good answers. So basically, our patient needed to go on another level of being cared of oxygen. So when we need to provide more oxygen to our patient, we basically refer to the clinical status of our patients, mainly. As the patient was desaturating despite being on face mask. And then as you can see, the respiratory rate were going high. But basically what we need to see is our patient really in shortness of breath and increased work of breathing. Previously, we discussed about signs and symptoms of patient who is hypoxic. And then as you can see, this patient was turning to being hypoxic with desaturation and increased work of breathing and the respiratory rate going up. And then we shall discuss in two groups, which patients and when can we increase oxygen, or we can leave one way of providing oxygen to another level, which is called escalation. And then from that point, we can move to the next slide, please. So as I have been saying, we will have different population, and then the goal to escalate oxygen will be different as we know. Adults or children who have been previously healthy, not pregnant, or not having other respiratory diseases will be having their group, and the way you can escalate their oxygen with the target of 92%,
Alana,
more
can you
than
move the slides?
92% saturation.
Alana,
And then,
can you shift? Okay.
Yes. And then COPD or chronic respiratory disease patients, as you can see, that their target should be 88 to 92%. Patients on some chemotherapy drugs like briomycin or paraquat poisoning, their saturation should be again around 92. Pediatric patients between 90 to 92%. And then those are the targets that you need before you escalate their oxygen to another levels. And in the next slide, we'll be discussing the way you can be moving from one level of providing oxygen to another one with your target, but with different oxygen delivery devices. As you can see, we have nasal cannula, which always need to be providing 1 to 6 liters per minute oxygen flow, and then they can help you to give an FiO2 from 25 to 40%. And then when your patient desaturates, despite providing oxygen via nasal cannula, you can go to face mask, as our patient was on face mask. And from there, you can go to face mask with reservoir, some of you responded via the chat. But also from the non-rebreather face mask, you can see that the flow is now high, 10 to 15 liters per minute, and your saturation, your FiO2, the fraction of inspired oxygen that you are providing the patient is going higher, 80 to 95%. There are some of the devices that we don't have in our settings, like venturi masks, which helps you to provide 2 to 15 liters per minute oxygen flow with your FiO2 going around to 60, the maximum. There is high flow nasal cannula that always we keep the flow from 30 to 20 to 30 liters per minute, but you can increase up to 60 liters per minute with your target FiO2 maximum up to 100%. But remember, when you escalate oxygen to your patients, remember when they respond well, you will go to the other opposite side and then go to de-escalate. You can de-escalate from high flow nasal cannula back to the nasal cannula, as you can see with your flow being reduced according to the patient status. From that, we are going to discuss cloning. You may be still giving this way of oxygen and with different devices, your patient being awake, but cloning, your patient will give a room to alleviate pressures on your compressed or alveoli, and then cloning your patient will again
Jackson?
increase. Yes.
Jackson?
Yes, Prof.
Can you wait a little bit? Alana, can't see. The slides are not aligning with your speech. Alana, can you move your slide? Next, next. So Jackson, can you comment this slide before moving?
Yeah, decision to escalate, as I discussed before, decision to escalate patients, we refer to our mnemonic course. Going more than 20 cycles per minute will give you a hint to provide more support, more or extra oxygen. And oxygen flow, when it is low, you may need to go to another level of, from maybe nasocannula to face mask as you increase the flow. And then saturation again will give you a hint on what is the patient really needs for our devices that you will need to use to provide the flow and oxygen or the FiO2 you are targeting. And then to escalate care will depend to if my devices are to clone my patient, or if my cloning is not really working, will I need to go to mechanical ventilation? This is very important when you need to ask patient. So let me give the floor to the colleague who will be discussing the way you can really escalate care on the next slide.
Thank you, Dr. Jackson. For the case update, our patient has been admitted in the hospital and transferred in isolation bed with 5 liters per minute by nasal cannula. When he arrives in the ward, the nurse obtained new vital signs with the saturation of 88%, a heart rate of 108, BP of 110/56, respiratory rate of 32, and the temperature of 38. Next slide. Now we are going to answer 4 questions. We are going to see at which level of oxygen should a senior doctor can be called, and we have to answer what other investigation can be requested for this patient. How we are going to see what is respiratory failure and the type of respiratory failure and the how critical care can be applied out of ICU. Next slide. Next slide. When should the senior doctor should be involved in this patient? The senior doctor should review this patient once FiO2 that is given is greater than 40% or is greater than 6 liters per minute via a simple facial mask to maintain an adequate saturation. 5 liters per minute, but was still the saturating. So this patient is needing more than 5 liters, even maybe more than 6 liters. Should need a senior doctor to be reviewed. Next slide. The other investigation that may be requested, chest X-ray should be requested to identify the structure of lungs with that patient who's desaturating. It can give ideas if the lungs contain lung infiltrate or that may be suggesting pulmonary edema or with lung consolidation that may show us patient may have pneumonia. You see this chest X-ray, bilaterally it has many opacities. In a breakout session, we'll talk more about how to do chest X-ray interpretation easily. We can go to the next slide. Prone position will be talked in the next session. Next slide. We are going to see respiratory failure. Normally, by definition, it's loss of ability to ventilate adequately or to provide oxygen, sufficient oxygen to the blood or systemic organ. We used to have 4 types of respiratory failure, but the main one we have to talk here, they are type 1 and the type 2. The type 1, which is hypoxic, type 2, which is the hypercapnic. For hypercapnic, the patient here is unable to exhalate the CO2. For type 2, type 3 may happen for patient from the theater, post-operative complication. Type 4 is due to cardiovascular collapse. Next slide. There are different signs of respiratory failure. On CNS, the patient may have altered mental status. The patient may present with cyanosis. Patient may develop a syndrome that called stress syndrome, which is manifested by tachycardia, hypertension, and aphoresis. The patient experience increased work of breathing that is manifested by using accessory muscles, nasopharynx, retraction, and the patient may show symptom of diaphragm fatigue that is called with a paradoxical thoracoabdominal paradoxical movement. Here, the chest is moving independently to the abdomen. Lastly, the patient may present with abnormal arterial blood gas. Next slide. Here, we are going to talk about critical care out of ICU. It's possible to have to manage critical patient out of ICU. I want to hear from audience what is means. For the first two, means. Any answer for meals? What is quick so far? What is CSI? I want to hear from you, audience. Good answer. Modified that warning call. What about quick so far? Thank you. Thank you, guys. What about key so far? Okay, thank you, audience. Quick sexual organ failure assessment. Thank you, Fidel. What about the last one, PCSI? The last one. Okay, thank you, guys. To manage the critically ill patient out of ICU, there are some tools that may help us to recognize patients who are deteriorating that need close monitoring, patients who have risk of high mortality out of ICU, and patients who may having a critical deterioration of respiratory system in the coming hours. Thank you, Prof, for the last point. The Muse is, as you said, is modified early warning system, early warning score. It's used for oral ages, and it determines the degree of illness. It helps us to know patients who are deteriorating and who need a close monitoring or who may need a further level of management. For this tool, they assess on cardiovascular, they assess the systolic blood pressure. There is a score for different numbers of systolic BP, the heart rate, the respiratory rate, the temperature, and the level of consciousness. Depending on which level of those tools, there is a score for them. Once the patient is get a score that is more than 5, it's associated with an ICU admission or high risk to have death before ICU admission. For the quick SOFA, is a quick sequential organ failure assessment. It is used to identify patients at high risk for in hospital mortality with the suspected infection outside of ICU. This tool is used to find the patient with high mortality out of ICU, not diagnosis of sepsis. It's applied for patients greater than 18 years. And also it gives us awareness of severe infection process that may give you idea to do further tests or close monitoring. For quick SOFA, it's a focus on 3 things. It looks on a Glasgow Coma scale. When it is lower than 15, you give 1 point. When the systolic blood pressure is less than 100, you give another 1 point. When the respiratory rate is greater than 22, you give another point. As long as it becomes 2 to more than that, it shows a patient who has great risk of in the hospital mortality with suspected infection out of ICU. The quick COVID-19 severity index is a tool that is used to 24 hours list of critical